Welcome to the Freedom Hub's Health Biz and Politics Show, where we feature innovators and disruptors who are working to deliver better and more affordable patient-centered healthcare, something the conventional cartel-driven system has lost sight of. I'm Jim Graypeck, and I'm joined by my co-host, Charlie Froman. And let me start with a few housekeeping items for those of you who are new to the show. I will do a screen share here. And Charlie, let me know if we see that screen.
Yep.
Okay, perfect. So our website is your-mp.com. That stands for Your Marketplace for Health, Wealth, and Freedom. And to learn about our shows and more, some good tabs here, go over to your Media Hub and click on that. And that will bring this up. We have been the webinars with our innovators, free thinkers. We've been doing this for 5 years now, regularly. We have two shows, the Wednesday Health, Biz, and Politics show today. Thursday show is a little more open, a broader platform, freedom, as you will, and we cover a lot of topics, health, wealth, and freedom. And then down at the bottom, you will see here, of course, our topics, our speakers, and we have the different upcoming guests, and we have our channels, our media channels, where these are posted by the next week at the latest, usually just a few days after. We are on BitChute, Brighteon, Rumble, and if it's not too out there, censorable, shall we say, in today's crazy world, you'll find us also on YouTube. So with that, let me see if there's anything else. Oh yeah, we're going to go back to the top. Just wanted to point out again our Buy Me a Coffee or Buy Us a Coffee. It's a volunteer operation. We appreciate your support. We put these out. And also, if you can think of better ways that we can expand our audience, like build this show better, and really support our guests and the public at large, let Charlie or myself know. And with that, Charlie, I turn it over to you.
Thank you, Jim. And let me share my screen. And I'm going to show another part of the website, our health partners. And the first one I want to show is Genexi, because this is a AI-driven assessment of your blood, DNA, and local environmental situation. And it was started by a integrated leader named Charles Benz, who recently passed away. And I'm showing this because early on in our 5-year existence at Freedom Hub, platforming leaders every week except holidays, Dr. Benz presented how to coach your doctor if you're a patient. And this is such a significant topic because over the past 3 years, those of us paying attention realized there was an epidemic, not with what the media tells us it was, but with chronic disease, which has exploded, coincidentally, with the reign of Tony Fauci at NIH, from 6% of our kids to over 50%, and a lot of patients discovered that their allopathic doctors were impotent to stop the chronic disease with their pharma offerings. And that exploded in turn in the integrated network, where patients were seeking outside the box healers to deal with their inexorable chronic illness. And this assessment is really taking over the market, where using AI and your blood, DNA, and local environmental factors, quality of your water and air, you could get a health score and learn functional medicine techniques and therapies to improve your health. And a lot of doctors are using this assessment to help them deal with their patients and get them into a higher quality protocol for real health. And that's going to be the topic today with Will Craghead, a physician's assistant and developer of business for what is called a DPC, direct primary care. And the other thing that you'll see at this tab at your Freedom Hub right below GenXC is the Wow Health Cash Appointments app. And Forbes featured how a couple of us in this venture sell not insurance, but rather sharing, which enables cash payment. And when patients shop on price, they educate themselves on options, which gets them out of the narrow pharma framework of thinking. And this is a place where providers can click that tab and list their prices and get paid immediately full price, including subscription payments that DPCs charge, which gives you more time as a patient. And that time makes the allopath doctors more integrated because they have more time to deal with the real issue, which is chronic disease. And with that, I'll stop sharing and just mention that this is a important presentation because we're going to coach patients how to act in the doctor-patient relationship. People overuse that phrase. It's not a relationship right now. It's a doctor-centric relationship where, because of their white coat, they have this undeserved position of authority. So undeserved, especially over the past 3 years, COVID, hysteria, and tyranny and bullying. And patients have got to bravely learn these questions that are combined in an acronym called ANERD, ANERD. And patients, in asking these questions that Will is going to explain, have to ask them in a gracious way. They can't be snarky. The doctor has gone through a lot of years of education. They deserve some respect, but the doctor has got to respond graciously as well. And if they don't, they should lose the patient. The patient has to be brave and willing to leave the practice and go seek a better practice. Now is the time. A doctor-patient relationship has to be an equal relationship. And that's going to restore the supply and demand curves, which we need because we don't have a market in healthcare right now. We have a cartel. With that, Will, I will stop my intro and let you tell us about this ANERD acronym, why it's significant, and how you think, if it's followed, it's going to change the market for the better.
Fantastic. Thank you, Charles, for having me on, and everybody else. Glad to be here. The idea behind this mnemonic came to me when I listened to different discussions, talking about risk-benefit discussions that we should be having with patients. And I listened to this great TED talk by a neurosurgeon. He's actually out of Norway. And he was having discussions with his patients about surgeries that he was performing. And this is how, a neurosurgeon, they're at the top of the food chain as far as surgeons go, in my mind, in the sense that they have the most training. They're almost 15, 20 years of school after it's all said and done. And that's how they put bread on their table, right, is to do surgery. So this patient one day asked him, is this really necessary? This procedure that he was doing. And this is a procedure he had performed dozens, if not hundreds of times. And he stopped and he realized that was the first time anyone had ever asked him that. And he thought about it for a minute and he told her, no, it's not necessary to do this. But this is why we would do it. And after discussing why that he was proposing they would do it, the patient said, no, I'm okay. And he actually felt okay about that, the surgeon did. And so the ANERD was born from this idea that we need to be having good discussions with docs in the room in which we don't have a lot of time. And so it's a quick 5-question analysis of any intervention that could be brought to the table in terms of medication or surgery or you name it. So the A is the ANERD. A is alternatives, N is necessary, E is evidence, R is risks, and D is do nothing. So questions would go something like, what are my alternatives to the proposed treatment? Is this really necessary? What is the evidence base for your recommendation? What are the potential risks? And then what happens if I do nothing? That would be kind of a simple way to ask those. And as Charlie mentioned, it's a good idea to make sure you're asking in a very curious way, because hopefully you genuinely are curious as a patient on these topics. That's why you're consulting with the physician that you're consulting with. Because the idea is that, physicians and other healthcare providers, they go through a lot of training, a lot of hours of presentation and reading and getting tested and, performing well on boards to get to the point where they can treat patients. Tapping into that knowledge and experience can be very difficult in a very short interaction or time frame. We make really big decisions in these really small exam rooms, and there's not often a great way to go about that. And so this is a simple way to bring to the table and open a dialogue that is more of a scientific approach to anything that's being discussed. And I mentioned in the post that brought this to Charles' attention was that if your doctor should love it, honestly. We often kind of nerd out on this stuff, and when patients ask us really good questions, we say, oh, that's a great question, and I'd love to talk to you about it. If you find yourself in a room in which, in an exam room, and the doctor's kind of peeved by any of these 5 questions, you may find yourself with the wrong doctor for you, or one that's just burnt out and overworked, and that's another topic for another day. But that's a real challenge too, is trying to cram 30 patients into an afternoon, and some docs do that, and it's wild to me where you get 10 minutes or less with a patient, because this kind of a dialogue can't be had, I don't think, in the course of 10 minutes. I don't think it matters how intelligent you are as a clinician. I think it just takes more time to really unpack these things, because it goes these questions really cut right to the value proposition in a scientific way, but also should help evaluate the values of the patient who's there. So looks like I'm having might have a crew coming in here. We'll see. So when you talk about the time component, I think this is a way to really utilize the time of a patient appointment most effectively, potentially, because when you think about the incentives at play, and this is not something I think it can be an issue, especially when you think about the surgical specialties, is the patient, the minute they enter the room in a surgical setting, they may not realize it, but they're kind of already at an odds, an unequal playing field when it comes to incentives. They're asking a mechanic, a surgeon, if they need repairs on their car. And what mechanic, isn't going to say, well, yeah, I need to pay my bills, so sure. Not to say that surgeons are innately, trying to take money from patients and doing it unethically, not at all. But they want to do surgery, and that's their base incentive. And so we need to have a way to make sure we're kind of have a check and balance on that. I think this is a great way to do that. And then you think about the health systems that are also at play. A lot of these primary care offices nowadays are owned by, and even some of the surgical specialties are owned by big health systems, where their bottom line is really revenue generation and trying to get as many procedures and hospitalizations to happen as possible. And so we need to have a good way to balance the discussion in the patient's interest. but also doing it in a very scientific manner and in a manner that will open a healthy dialogue. Unfortunately, as you talked about in the past 3 years or so with COVID, there just were a lot of unhealthy dialogues being generated on both sides, both the patient and the doctor's side, and public health is another area of that. And it was really unfortunate to watch. I was treating patients from the emergency department mainly during those 3 years, and it was unfortunate that we had such an imbalance of discussion, so I hope that this gets corrected through different initiatives like this A-Nerd mnemonic that anybody can use at their next doctor's office if they'd like.
That's great, Will. And folks, if you want to ask a question, just find the raise hand icon, please, under the reactions tab, or on some of your Zoom windows, it might be after ... or more. Let's go through that mnemonic, or is it also an acronym if it's a word that stands for other words?
Yeah, I guess an acronym and a mnemonic. an acronym in that it's ANERD, and a mnemonic in the sense that, look, you try and be a nerd a little bit when you're going to these office visits. And if you can remember, I just need to kind of be a nerd. That would be a way to remember the acronym.
Yeah, it's kind of like, Forbes kind of feature how we upgrade folks from insurance to sharing. And with our concierge shopping assistant, we help them shop on price. And that intimidates some of our prospects or new members, in that, how am I going to negotiate a price? And we say, no, you don't have to. We'll do that for you. But the patient on that supply and demand curve, that demand curve is so limp. Like I said at the intro, they're just slapping down their Blue Cross card and asking what their copay is. And like you said, once they're in the specialist office, the mechanic is going to recommend the intervention. And we have a terrible overutilization problem with back surgeries, neck surgeries especially, or heart stents, that kind of thing. What have you discovered in your search for, rebalancing that utilization dynamic? Perhaps, from your DPC experience, how does that monthly subscription, for example, stem the overutilization problem? The necessary part, the N part of your unerd mnemonic.
Biggest thing I think in which it helps to restabilize the incentives is through time, and also the financial implications of paying someone a monthly membership, whether they see you 10 times or whether they see you 0 times, really is a powerful way to do business with someone, because it's very hard in the medical world to monetize wellness, right? It's hard to make money off of somebody being well. And even though that's the end goal of hopefully everybody who's practicing medicine, but the DPC, or direct primary care model, or subscription model for primary care without insurance, helps to get it closer to that, in the sense that, I'm actually incentivized in the direct primary care world as a provider to see patients less, because it's in a way less work. So if I'm keeping people healthy, they shouldn't have to see me very often, but I'm also not disincentivized to see them, because I gotta make sure I'm taking care of these people, or else they're gonna leave, right? They're gonna go find somebody else to take care of them. And so the overutilization thing is because, to help curb overutilization, we have an interest in the patient's financial interest as well, in that, because we know that they often don't have health insurance, we can help guide them through the medical world in terms of telling them exactly what things cost, because we help most DPCs help help generate cash pricing for their patients in different areas of medicine, like medications, labs, imaging, obviously even some specialty visits. Like us at Arc Family Health in Phoenix area, we have a specialist list, and we have a lot of cash pricing for consults and specialty tests that these specialists will do, as well as cash pricing, for CT scans, ultrasound, MRI, X-ray, and meds and labs. So we can help let patients know, like, look, you can get that MRI done. But why don't we consider doing some physical therapy first? But when we, we'll let them know, like, look, if you really need the MRI, we can easily just pull the trigger on it. Another great thing to talk about in this regard is antibiotic prescription. 2 years ago, I saw a statistic that there were over 300 million antibiotic prescriptions written in the United States. That was almost one for every man, woman, and child. What percentage of those do you think were actually necessary? And it's a pretty scary thing to think about, because I don't mean to throw urgent cares under the bus, but I will a little bit. But it's also an incentive thing that in urgent care centers are often, they're just pitted against this expectation that patients have. It's almost like some people treat, not that I think it's a good thing, but a lot of patients treat urgent cares as like an antibiotic prescription vending machine, where they pay their copay, they pay their $100, $200, whatever. They've got a cold for 2 days, and it's clearly a virus, and they go in expecting a prescription for antibiotics. And unfortunately, the urgent care is often, not always, but often owned by some kind of a health system. So they want to make sure that their quality scores are good, even though that's really quality and patient satisfaction are two different things. But their patient satisfaction scores are high, and so they're willing to write prescriptions because it's, they're trying to just do their best in the world in which they operate. So direct primary care is great in that regard, because we can say, look, we're building a relationship with people. All the time, we'll see patients they're 2 days, 3 days into a virus, and I'll explain to them, look, you have a virus. Viruses aren't living. I can't kill a virus with an antibiotic. This is just going to have to run its course, but don't worry. If you get worse and you get a secondary bacterial infection of the sinuses or lungs or wherever, we'll write you an antibiotic. We're not telling you no antibiotics ever. We're just saying, let's make sure we're using them appropriately, because risk benefit, the risk is highly in the risk, or highly tilting towards risk when we write antibiotics 2 days or 3 days into a respiratory illness, and no benefit. It's most bacterial sinus infections don't set in until after 7 to 10 days. So that's one area. That's a long question, or a long answer to a short question.
That's good. Not to mention the overutilization incentive at urgent care, doc in the box type places for the score.
Yeah, and it goes back to I forgot to mention, sorry, in the presentation on ANERD, there's this bias, and this is a bias anybody can have. It's not just us as clinicians, but it's a bias called Maslow's hammer, generated by Abraham Maslow. And it basically is when all you have is a hammer, everything looks like a nail. You've probably heard that before. And that's going to an urgent care. That's going to a specialist, asking them what's wrong, or asking them, do I need the surgery that you perform, right? And so not that everybody falls prey to that, but it is a legitimate bias that any rational human operating under economic incentives in some way can fall victim to. So.
Yeah, I was going to add, it's not just that search for a good health score that generates the overutilization incentive with that antibiotic, but I also think I saw on LinkedIn, Eric Bricker does these great teachings on healthcare economics, that the scam called MLR, minimum loss ratio, that insurance
medical loss ratio.
Yeah, the insurance companies gamed for themselves in Obamacare, as it's sort of like the briar patch. Don't throw me in the briar patch. Don't control my prices with the minimum loss ratio, which requires them to spend 80% of their profits on care. They've gamed it so that the pharmacy benefit managing companies that they co-own in some cases kick back in commissions a percentage of that prescription that is either helps their MLR or offsets it or is exempt from it outside of it. So the insurance companies do not have an incentive to control utilization, nor do the
You're
hospital
absolutely right.
systems. They
You're
collude.
absolutely right. You're absolutely right. It's like thinking of a pie chart. Think of a pie chart. In the MLR, I think it's medical loss ratio, you got like 15 to 20% of that pie, depending on the type of plan that an insurance carrier can profit off of premiums. So you think of a pie chart of premiums they're bringing in, only 15 to 20% of that pie chart are they allowed to take in as profit. So they have to make sure they're doing something else with the rest of that pie chart. Well, if you think about the economic incentives of this over time, a lot of these insurers are publicly traded. So really their bottom line is to make sure their shareholders are happy. So how do they generate more value for their shareholders year over year? They got to make sure that pie, because they're constrained to 15 to 20%, they got to make sure that pie just gets big and big and big and big and big, which is exactly what we've seen since Obamacare. If you read the book Catastrophic Care, fantastic book, talks about the incentives at play when it comes to the Affordable Care Act. They had a decision to make with ACA. They had a decision to make either to address access to care, meaning ability to get care, or cost of care. They chose access instead of choosing access through cost, which is what the market would do. They chose access. Just give everybody an insurance card and let's just see what happens. And the effects have been catastrophic, which is why that book's called Catastrophic Care. Highly recommend anybody read that book.
Yeah, indeed. Wow. Also, going back to something you said with PT, instead of the MRI, that test, let's try some physical therapy. I like that. And that gets to my next question about integration. Some of the DPCs we've had over the years have used that time to upgrade their own quality, skills, and knowledge to become not just pharma salesmen, but integrated physicians, healers. The inclusion of PT to me, it represents an example of that learning, that growth. What is your experience with that when you have that time for the monthly payment and you have these chronically sick people that don't respond to this or that prescription? PT is a great answer. What else has been your experience with this broadening of healing and openness?
It's a great question. The thing we haven't had a chance to address yet is lifestyle medicine. Anyone interested in a Western, I should say, not necessarily Western, but it was started by a lot of Western docs who were frustrated, Western medicine docs who were frustrated by the fact that the chronic disease burden is really become insurmountable by the typical, most of the typical interventions you'll see in a Western, allopathic medical office. So there's an actual American College of Lifestyle Medicine. You can go to lifestylemedicine.org, and there are 6 pillars to lifestyle medicine that aim to address exactly what you're talking about, trying to bring back the discussions that really should be happening in any doctor's office, especially primary care, talking about what are you eating? How often are you exercising? What's your sleep like? What's your stress level like? Are you smoking, drinking, doing drugs? And what are your personal relationships like? Those are the 6 pillars, addressing the person as an entire human, and acknowledging that while there isn't a blood test to see, exactly, there isn't a great blood test to see like, okay, are you super stressed? There are ways of assessing and treating stress in a setting in which you have time. Making sure that people are getting exercise. If there's one thing I can convince anybody to do to improve their health today, it's exercise. That's the most potent drug out there for someone's health, it appears. More so than, there was a recent study that came out showing that exercise, I can't remember where it was from, who did the study, but it was exercise was shown to be 1.5 times more effective for anxiety and depression than SSRIs or therapy alone. I'm a big believer in therapy. I'm a big believer in SSRIs in severe depression, but I'm not going to say, oh, don't worry about that exercise thing. I'm going to make sure that people are I'm going to really talk about that, because I've experienced that myself. I think anybody who has exercised ever in their life can acknowledge that, yeah, while it was maybe hard, I actually felt better afterwards.
If I can jump in, it looks like I'm seeing more and more articles and studies showing that intermittent fasting has been a real boom to people's health. Another great intervention. One that I think also a lot of us have trouble with,
It's
We-
yeah,
you-
that's a trick.
Yeah.
It's a tricky one. I was I was a big proponent, of intermittent fasting initially. I'm also I'm a little bit more skeptical. I don't think it's for everybody. I think it's I think it's when it comes to diet, the more I learn about diets, the less I like diets. Okay, like specific diets. I think that some of them have a place, but it really depends on the patient. I would not tell a room of 100 people you should all do intermittent fasting. I think that's a bad idea, because it's nutrition. Of all of the interventions that we can try and bring into people's lives, what people eat and how they eat, how often, that's one of the most tricky things to from an implementation standpoint. It's difficult. B, it's also we don't have a perfect evidence on this, and humans are really hard to study in the area of diet and nutritional biochemistry, as Peter Attia calls it. He's a great
Yeah.
voice in this area.
And then you've got, you look at your neighbors who might be Italian, Chinese, Indian, different diets, different cultures, especially in America. Everything's mixed up. Where do you start, right? Sometimes.
Yeah.
And then,
Yeah, because when you start saying to everybody, a room full of 100 people, just do intermittent fasting and you'll be healthy, that's just not a nuanced approach, and it's also not scientific. And I think it may end up doing more harm than good for a lot of those people, because they will sacrifice their protein intake, and that is not good. Not good for most of those people.
question, Will, a nerd is a great, is it a program? I mean, I know you're doing this at your practice. What are you doing, or how can we help you, for example, to get this out to more DPCs? Or, I mean, obviously the incentive is more towards the DPC world or specialty care than allopathic medicine, and as you said, it's good for you as well. There's a balance there, and it helps everybody. So, are you doing anything, or what is being done to push this out there, to make more practices aware of it, to make more patients or patient advocates aware of it?
Anytime that I refer a patient to a specialist, I'll include it. I'll either text it to them, my patients, or make sure to send an email out to them, so that they have those questions in hand when they go to see the specialist. They can make sure to have them handy to ask. This is not something I've dedicated a lot of time to, trying to get to, blow up in anything on a larger scale. But I think it's important. If I were a more notorious figure, or somebody who would be asked to do a TED talk, great. I don't even know that I'm the right person to do it, but I think what we can do is make sure that we're telling our friends and family about it. Easiest thing you could do is just generate an email and take these questions and send them to people and say, hey, look, this is a good idea to ask your doctor anytime they're asked, they're talking to you about a big intervention. And I will say, working in the emergency department, that's like the last place you want to have to make quick decisions, but it's also probably the place we make the fastest decisions when it comes to people's health. And so, there are ways to, we can still address these in the ER. We do it all the time, even for people who are having acute strokes or heart attacks. But the reality is that's the end. Like that's like the end. That's like the last place you want to have to be making these decisions. You know, the reality is you want to help prevent those things from happening to begin with. But you can still have these discussions in the acute care setting in the hospital as well.
Yeah,
So.
well, Charlie, this might be good to share with some of our DPC guests or the association, some of our guests who've been running the associations. What do you think?
For sure. Continuing on that mnemonic acronym, I have a question for each one. And we covered overutilization. To finish up on alternative options with the PT and functional medicine, lifestyle medicine, there's you kind of mentioned the troublesome politics around COVID. There's a built-in political barrier to healing and the art of doctoring, and that's medical boards. A lot of doctors trying to treat early the past few years have run afoul of medical boards controlled by lowest common denominator thinking, maybe influenced by financial profits. Have you had any experience with medical board bullying, or how that could stand in the way of a big thinking doctor, creativity, that kind of thing?
I haven't had any experience in that personally. I've read articles from some of these docs who were, quicker to prescribe hydrochloroquine or ivermectin earlier in COVID, having trouble with their licensing boards, which I think is unfortunate. I do remember seeing, there was a time too during COVID when I was writing ivermectin, and like I remember getting kickback from pharmacists, saying they weren't willing to write the medicine, and I would have to have a serious conversation with them if they were trying to practice medicine or not. And they were getting internal memos. A lot of these pharmacists, like retail pharmacies, they were getting internal memos about those medications, which I thought was interesting. I asked them to share them with me. I never did get any of the pharmacists to share with me what these memos were. So I don't have any personal experience beyond that, other than what I've read. I did have a really close friend and colleague have an interesting discussion with the medical board, and it wasn't the medical board, excuse me, it was the county's medical association, and they were, it's a separate topic, I guess, but they were. Without even surveying their group of physicians in the county, the largest county in Arizona, I should say most populated. They didn't even survey those physicians regarding their support for abortion, and they just said that they just put a briefing out saying that everybody supported, everybody in the medical association did support it. And I think those kinds of things are unfortunate and an opportunity for improvement.
Jim, you may have stepped out. Dr. Montalvo, do you want to unmute yourself? There you go.
Yeah, thank you for asking me to comment on this lifestyle integration. I think it's extremely important that we have to look at some of these lifestyle, as this gentleman stated, being a naturopath myself. And one thing I know that functional medicine has done is basically copy the naturopathic outline that's been going on for hundreds of years. I know for a fact, and also training osteopaths for 13 years up until the time I was kicked out due to the fact to get my opposition to the bioweapon shot as well as to the masking. I think that's one thing that's missing in health care as opposed to disease care, is looking at people's lifestyle as to the cause of their disease state. And typically, in my professional estimation, usually diseases are caused by lack of minerals, lack of vitamins, or both, as well as somebody's mental state, which is also caused by lack of minerals or lack of vitamins. These SSI things shouldn't even be looked at due to the fact that there is not even a blood test that shows how the brain chemistry is working with these things. And we know for a fact that these SSIs have also been implicated in mass shootings. So that's one thing that we need to look at in healthcare. If we're going to provide true healthcare in this country and true disease-free care, then we need to be looking at lifestyle integration into whatever we're doing, as opposed to taking pharmaceutical drugs, which unfortunately a lot of them, and I've studied a lot of them, are not even properly tested. And this thing about that we've never tested lifestyle, that's bunk. I can go to PubMed and I can pull up literally 1 million studies on lifestyle and vitamin intervention as well as food intervention. It has been done multiple times. The problem is it's not profitable for the pharmaceutical firms. I just want to make that statement.
You're totally right on that part about the it can't make money off of it, and it is a real challenge that our medical system is not doing a great job to wrestle with, but it's something that we deeply need to talk about. There was a book written last year by a Harvard family physician and epidemiologist, John Abramson. It's a fantastic book called Sickening: How Big Pharma Broke the US Healthcare System and What to Do About It, something like that. Highly recommend it. It goes into a lot of the quandary that really is now the intersection of big pharma, the journals, like a lot of the big journals, and getting these studies published on these meds, and peer review process. It's really fascinating. I used to think peer review was like, oh, it's like 2 thumbs up, like sounds like a great idea. Well, it turns out peer review is not what we think it was. Peer review.
It's been corrupted. It's been corrupted. The whole system is corrupted. That's the problem. You cannot trust peer review anymore. You can't even trust the medical journals. Look at all the medical journals that were going with this bio shot. They were just saying all this stuff that, oh, it was tested, it's 90% effective. And I know for a fact, when you really look at the studies, no, it wasn't even close to being effective. So this is the problem.
It really is a problem. When you read that book, it makes me ask so many questions about what is the future of that relationship between pharmaceutical company, journals, even training institutions, medical schools, and the FDA. So it's a big question that we're not doing a great job asking. However, I agree with you that we need to just focus on what we can focus on, and we know is safe, which is the lifestyle part, and hopefully we can do so well at this lifestyle part that we aren't even candidates for these meds. They're not even close to being. Those meds aren't even close to being indicated in our situation. That would be the best case. But I highly recommend reading that book. Anybody who's listening, Sickening by John Abramson.
What was that first book again you mentioned?
Catastrophic Care, David Goldhill.
Catastrophic Care. Okay, thanks.
Yeah.
Dr. Ward, your hand is up.
Oh, hi. Thanks for calling me. Yeah, I'm a traditional naturopathic doctor, and what I'm seeing, it's upsetting me in a sense that we have these highly trained medical doctors going through 8, 10, 12, 15 years of medical school, realizing, oh, we're not teaching people how to eat properly. And I think what, medical care is fabulous when it's necessary. I like neurosurgeons. I mean, we have to have a neurosurgeon and osteopathic surgeons, but if we could have a division between medicine, medical care and health care that would be, because I'm not licensed, and frankly, I don't want to be licensed because the school I went to was not co-opted by the pharmaceutical companies. It's, not included in a licensing qualifications, which is fine for me because then you're up against basically a gang of, pharmaceutically infiltrated people. And a lot of the medical doctors want to bring that paradigm of, a symptom for a drug or a symptom for an herb into the naturopathic care. But I can see that they're waking up, and that's making me happy to see someone like you waking up and knowing, but really you don't have to take a medical doctor with that kind of training to do that kind of work. There could be a separation, and know that healthcare and medical care could be two separate veins. So I'm wondering if anyone if you have any thoughts on that.
Oh, sure. Yeah, I agree that we need to really closely investigate who does what, and because we haven't really had close discussion on this over the past 30, 40 years. I would say that the Western medicine has done great things for the world. I don't think anybody can argue that, right?
Yeah.
With the advent of and what I mean by that is like scientific approach to treating disease, understanding pathophysiology, and then deriving ways to treat that. That's a science that can be analyzed by a scientific method and shown to be as true as we can understand. And things like antibiotics and surgery.
Mhm.
Where would our life be without antibiotics and surgery over the past 100 years? You would take our health outcomes and we would plummet to that of a third world country overnight. It would be a scary world to live in, honestly. But those things came about in treating acute illness. Acute meaning days, right? Days of illness that need to be treated now before somebody succumbs. That was a far cry from the days where we were doing things like bloodletting, and that was seen as the right thing to do at the time. A couple hundred years ago, bloodletting was one of the only things that people saw as a potential treatment for somebody's ailment, and it's been hypothesized that that's how George Washington died. He probably had either a really bad case of strep throat or a peritonsillar abscess, but ended up getting so badly bloodletted he might have died from that. Anyways,
Actually, that can be a good thing because I actually practiced phlebotic, therapeutic phlebotomy to help discharge excess iron in the body at regular.
Oh, for sure.
That's not the same.
Assuming not everybody has polycythemia, but you think about the timeline of how interventions have taken place. We've mainly developed medical interventions to treat acute illness, and we still do well in acute illness overall, I would say. The problem is 40% of the country now is obese, and most of the things we're seeing are chronic illness, and we are not doing very well at treating chronic illness, diabetes, hypertension, stroke.
Well, right.
heart attack.
And the FDA is doing nothing to help correct our food supply, and the glyphosate that's just in all the food now, and the fruits that have been hybrided that are way more full of sugar than they used to be, and
there's definitely something to be said. There's definitely a lot to be said on that front. I'm not the voice of authority there, but reading ingredient labels nowadays makes me a little scared.
Yeah, and most of my clients, it's basically having to correct what has happened from being prescribed drugs like PPIs for heartburn when they're sitting at their desk working at the stock exchange. It's like, well, things like that. But I have a great respect for medical doctors, and my niece is a medical doctor, and there's a necessary place for that, surgery and all of that. But there could be I think we need more of a separation for general all over health. Just, let the naturopaths and natural doctors take care of that, and let the medical doctors do the great work that's necessary in medicine.
Okay. Let me jump over. Charles, I think it'll be the last question, and we can wrap
Thanks.
up.
I noticed, Will, when you mentioned allopathy's success over the past century, you didn't mention vaccines. And in your mnemonic, a nerd, risks, what are the risks? Especially as Robert F. Kennedy Jr. keeps taking market share in the Democratic primary. He's now at 20%, which is amazing. And the pharma ad dependent media will continue doing anything possible to censor him, because he's extremely dangerous to the special interest. He's got decades of practice as a litigator, making bureaucracies and special interests pay for their environmental insults, whether Monsanto or vaccines. And vaccines are at a crossroads. I think your profession is pretty excited that the medical mandate from CMS is ending any day now. And your profession has been depleted by all the nurses and doctors who left over the past few years, instead of risking their lives with that increasingly dangerous experiment, which now is probably implicated in excess death. Do you see your profession being a little bit more honest with the risks of vaccines, not just their benefits?
When people ask questions, I hope that it'll be talked about. I'm also not like I'm not the voice of authority here in knowing all of the risks, but I think that I hope that anybody will be willing to be humble enough to say, look, I don't know the risks, or let me look into it. I do. That is one of the things that really, made me sad about the rollout of the vaccine. Was the risks weren't really talked about. Obviously, because it became very political very early on, nobody could really think rationally about the vaccine in any real way. I mean, it was a matter of 30 to 60 days from when Kamala Harris and Joe Biden were saying they wouldn't take the vaccine because it was a Trump vaccine, to them being, hugely on board with it because it affected them politically. So do I think that the trickle down of all of that to the exam room or medicine as a whole, being more open to the idea of discussing risk when it comes to vaccines? I mean, I hope so. I also realize that once you slide down that self-justification pyramid, as is put by a great the book, I highly recommend the book Mistakes Were Made But Not By Me. Another really great book that talks about cognitive dissonance. And once people go down that road of a little bit of cognitive dissonance, they can be very quickly not willing to admit that they were wrong, because their brain won't let them see that they were wrong. It's a self-protective mechanism that our brain has. It's a human condition, that anybody will, when challenged, can very easily defend their position without being willing to examine things rationally. But I hope that when it comes down to it, people will be willing to have an open and honest discussion. It may still take 5-10 years for that to happen. And I think that's really unfortunate because, I have seen firsthand nurses quit and leave, or find some other area of medicine to work in that did not require them to get the vaccine. Have I seen harm from the vaccine? Yeah, absolutely. Have I seen benefits from the vaccine? I think so. Do I think that from what I've seen in my limited understanding and limited viewpoint, do I think that the approach to mandating it on everybody was the correct approach? I do not at all. I think that it was, the wrong approach. I don't think mandates work, especially in America. I think one of the last places that we should have tried to mandate. And I think we need to really be open and honest in our discussions about, in the coming months and years about the vaccine and vaccines in general, being willing to examine their utility. While I am a believer in the idea of vaccination, I still think it requires discussions on risks and benefits to the best of our understanding. Will we get it right? No, probably not always get it right. It's not as they're if you go back and examine the beginnings of vaccination, I mean, it was really similar to the COVID vaccine, really similar, everybody, because it was a new technology. People were less excited to embrace it, which I totally understand. I myself was very skeptical of the mRNA technology, and I didn't get vaccinated, not because I am against vaccines in general, but because me being front lines during the COVID pandemic, I was in the emergency room. Guess how many 30-year-olds I saw coming into the emergency department dying of COVID? Virtually none. And if they were, not to say that there weren't, and I don't want to be unsympathetic to those people who lost family members who were that young, because I did see people really young get hospitalized. They had at least one comorbid condition, and that comorbid condition was at least morbid obesity. We're talking people who were 300, 400 pounds and less than 6 feet tall. That was the most common, comorbidity I saw and if I saw a patient and I saw that they were looking kind of sick, they had COVID, if I looked at their BMI and I saw it was over 30, 35, certainly 40, I would say, yeah, they may not do as well. So, anyways, that all to say, I hope that discussions on risk can be more open and honest. And people won't get scoffs, from either side. Okay, that's just not the right approach. Any of us have our own bias, whether we're the patient or we're the doctor. And I think it's healthy to acknowledge that and address it and say, look, I am skeptical of vaccines at baseline as a patient. You can say that. And hopefully, if the doctor is empathetic, they will say, okay, thank you for sharing that with me, because I need to know that, we need to know that about somebody's before we can even have a discussion. Whereas if we start getting in a discussion about something and we don't actually know where we are, and being willing to be vulnerable about where you are, you may not get much accomplished in that discussion. And if somebody does share being, that is vulnerable about, like, look, I just don't know. I just don't feel like these things work, or I feel like it's dangerous. The other side needs to be respectful and meet them where they are and say, okay, I am really appreciative that you shared that with me. Now I know how to go about this discussion.
That goes right back to a nerd. Is there an alternative? Maybe homeoprophylaxis, for example, or something. Do I really need it? What's the risk? To your set of questions there, right? It's another intervention. Let's talk about it.
Yeah, I agree, and have an open and honest discussion. I think the biggest failures of public health and the medical world and the government, whatever way you want to try and boil it down, all comes down to trust. And that was the biggest thing I think has been lost, or should say not fully, but it's been a big dent, big bite taken out of trust, unfortunately. And it's going to take some time to fix that. But everybody needs to be be willing to have discussions on this topic, because, while someone may claim that the vaccine did zero good and was only harmful across the board and only, hurt the human race, I think that's an unnuanced view. But to say that vaccines are good and you should vaccinate your 6-month-old, I mean, that's just not something I can really get. I should say the COVID vaccine, that you should vaccinate your 6-month-old against COVID. That's just not something I can get behind. And I think that the evidence bears that out. But that's not, I'm also not the voice of authority here. I'm not an epidemiologist. I'm not a vaccine scientist, but from the reports that I've heard and people that I follow on this area, someone who's really got a great nuanced view on this, I think, is Zubin Damania, ZDog MD. He's got a great podcast. Vinay Prasad. These guys are great voices on this topic of making sure to bring back the trust as best as possible.
Well, I don't think ZDog will have any role in restoring trust. That guy has been one of the worst
Really?
vaccine Nazis in history. But Vinny Prasad has come a long way to being more open, so good for him. Why don't you close by answering one of the earlier questions? If a nerd gets traction, how significant will that change the health market for a better?
I think if a nerd gets traction, it will reestablish the patient-physician relationship and balance it back to the patient, and honestly give the patient more ability in a short time frame to understand a very complex topic as best as possible. And as long as there's the underlying trust there, that this doctor that they're consulting with isn't just lying through their teeth, they can make some decisions that will hopefully get that patient the care that they need, and that it will hopefully be the right thing as best as we understand it via the scientific method.
And how can folks reach you?
They can reach me on LinkedIn. It's a great place to reach me. Just find me, Will Craghead. You can always send me an email if you'd like, will@arcfamilyhealth.com.